Good morning, everybody. Good morning. And thank you for attending another MS Views and News Symposium. This is our fourth in Central Florida. We used to call it the Orlando Symposium, but because we want people from Plant City or from the Tampa area or coming up from other regions of Central Florida, we want them to know that, hey, we got your name in part of it, and so we want you to be here as well. So, yes, this is our fourth big program like this in Central Florida, and I see we have a crowd today of about 100 people, and that's a great thing. And, you know, this is what we want to see at our programs, is we just want to know that we are providing the types of programs that are drawing people to these programs because we're providing something that they're not getting from other places. So, again, my thanks to all of you for coming today. For those that don't know, my name is Stuart Schlossman, and I, too, have multiple sclerosis, and that's how this all began. Because once upon a time, as many do know, others don't know, that when I was diagnosed, the information just wasn't there for me to learn from, and so being internet savvy, I was able to get on the internet, find the information, provide it to family and friends, and give it to others in a support group that I did attend at that time, okay, and was providing it to them, getting the information, reaching out to other people in other support groups, and lo and behold, this little information piece that started off once with 12 to 15 people is now reaching people in over 90 countries, and our database is now up around 35,000 people. So, we know we're doing a good thing. Before I continue with my rant today, we want to thank those that gave us dollars to do today's program. We want to thank Genzyme, a Sanofi company. Genzyme, as you know or don't know, makes Aubagio and Lemtrada, and you're going to hear about this today as well. Also, we want to thank Teva. Teva Neuroscience makes the Copaxone, and Teva is our breakfast sponsor. Genzyme is our primary sponsor. Teva is our breakfast sponsor. We also have Genentech. Genentech is hopefully going to be coming out with a product near soon. I think they're in phase 3 of this research on a product that you might hear about today as well. Mallinckrodt is one of our sponsors. They make the Acthar gel for those that have relapse. You might hear about that. You might know about it. You might have used it. Also, Accorda Therapeutics has Impero, the walking pill. And so we want to thank all of them, and I want to thank them, and I hope you all do too, so thank them. Recently, we did a program. Last weekend, we did a program in Chicago, Illinois. It was our first program to do in Illinois. We had 87 people attend that program. Next year, when we do it again, we'll easily have a crowd like we have today. We'll get over 100 people because those people that were there learned that they're going to tell everybody else. Next month, we're going to be in Indianapolis. In June or July, we're going to be in Louisville, Kentucky. Later on this year, we're going to be in Atlanta, Montgomery, Alabama. We're going to be in Charlotte, North Carolina. We're going to be in Mobile, Alabama. We're going to be in other places outside of Florida. Why? Because people want us to get these programs to their locations. So that we are starting to provide this, and we're able to, again, I have to thank the pharmaceutical industry. They are helping us to be able to provide these programs so that way others can get educated. I just wanted you all to know how lucky you are that we are in Florida, and we do so many programs in Central Florida, whether it be in Tampa, Melbourne, Orlando area, that you can attend these types of programs. So, today's format, we have the neurological aspects of multiple sclerosis, and we have Connie Easterling, who you all know, and Patricia Pagnotta, who are going to be our first speakers here today. Following them, we're going to have a Q&A, okay? Please hold all your questions until we actually get to the segment of the Q&A, and then they will answer your questions, okay? After that, we're going to take like a 20-minute sort of break from the big speakers of the programs that you have the agendas on your table for, and we're going to let our social worker, MS Views and News is now providing a community service, a free community service for all of you. We have a social worker. And by the way, speaking of the social worker, we would like to know how many of you are interested and feel a need for social work. If you are, we're asking you to please put your name and email on the pad of paper that's on your table now, and they will go around and they'll pick this up at the end of the program. Listen to me. I tell everybody to turn off their cell phones, and mine is ringing, right? It's because we don't usually start programs this early, so, you know, it's going off. It's my 10:15 alarm to tell me it's 10:15. Okay, so after lunch is served, all right? Firstly, thank you for taking part in our continental breakfast this morning. We did that because we're starting the program early. We wanted you to have something in your belly because the lunch doesn't start until 11:50 a.m. And after lunch is served, then we're going to have, or during lunch being served, we're going to have our social worker talk to you for a few minutes. After her, we're going to have our attorney come up here and speak with you about caring for the caregiver. So for all you caregivers that are around, this will be a great topic for you to listen to. And for all those with MS that are here with a caregiver, listen to what he says also, so that way you can give them a break from time to time. Okay? Thank you. Then our closing act of the day, our act, is Jeffrey Siegel. And Jeffrey Siegel is going to be here and have to work with you and trying to show you how to reduce pain for those that have pain in their bodies, maybe from spasticity. He'll help you, teach you a few techniques to help you lose that need for pain, right? All right, so I don't want to keep rambling on and on here, and neither do you want to listen to me do this. So without any further ado, let's get started with Connie Easterling. Thank you. Welcome. You have the clicker? Oh, you got the clicker right here.
I don't know if I can see that that prompter over there, but I'm going to try. Oh, this is better. I got my glasses on. So it's so nice to see all of you here today, especially those that are new. Of course, my people know me, and it's always nice to see you at these programs. And but there are some new people here today. Look who's here. Hello, Tina. I didn't get to speak to you. I usually try to get around to speak to every table. Today was pretty busy when I got here, so I didn't get a chance to do that. But if you'd like to speak to me at some time, I'll try to make myself available today. So Stuart took some of my time, so I'm going to just take my time right back because he holds you pretty close to... He holds you pretty close to the time limit. So he asked me to speak on the current treatments, which we'll spend not too much time on those because many of them you already know, but we're going to spend a little bit more time on the emerging therapies and some things that are in the pipeline, and then we'll talk about adherence, which is an issue that's true to my heart and very difficult for many of you, but we'll talk about how it's important. I did want to say Tricia's going to come, Patricia Pagnotta, she's going to come speak after me. You're very fortunate in this state because you have 3 people from this state that are on the executive board of the International Organization of MS Nurses. Tricia, we're voting for her now, but I have every confidence to feel she's going to be secretary next year. Then if you know Megan Weigel, she is a nurse in North Florida near Jacksonville, and she is president-elect. And then, of course, I'm president. But we're very excited that our state is so active worldwide in the issue of multiple sclerosis. So if I didn't have to be at this mic, I would be out there because I'm a wanderer. So I just got told to stay at the mic. So I can take it out? Okay. Great. Okay, some of this I want to point to a couple slides. So let's talk about. Oh, good. Okay. So we know that MS is an immune-mediated disease. It's also inflammatory. It's chronic. Sometimes it's degenerative, and that's what causes a lot of disability. We don't know exactly the environmental trigger, but each of you may have a different environmental trigger, and that's why MS is so different in every person. There are other factors that can lead to MS, but you have to be genetically predisposed to the disease. We'll talk a little bit about that in a minute. The hallmark of MS is those inflammatory plaques and the loss of axons themselves. The plaques are very classic. That's what we look for on MRI. MS is characterized by relapses and remissions, and then and 85% of people with MS. And then eventually, those relapses leave you with some level of disability or residual symptoms. But it is the most common neurologic disease in young adults in the world. So Very common. So the causes of MS are that the immune system becomes dysregulated, actually. It gets confused. So we know that there is a genetic predisposition, and we know that because there's been lots of twin studies that looked at the likelihood of if an identical twin has MS, the other twin has a 35 to 40% chance of getting MS. There's been lots of studies there. We also have identified an allele, which is a genetic piece. And the HLA-DRB115 is the current one, and it occurs in the majority of MS patients, but not in all the MS patients. So we now think that there may be other genetic pieces that may be causing MS. And then there's environmental factors, where you grew up the first 15 years of your life, what you're exposed to. You know, MS is more common in the north, away from the equator. There are a number of infections that have been studied. Epstein-Barr, which causes mononucleosis, and HHV6, human herpes 6, is another one that's been studied. More recent years, they've studied chlamydia, and that is one as well. Vitamin D deficiency. We've been checking vitamin D since 2009 in every MS patient in our center, and there's not one has ever come back with a high level. They're either low normal, very low normal, or deficient in vitamin D. And then we've learned in recent years that smoking can lead to MS, can be that one trigger to MS, plus individuals with MS who smoke have a more progressive outcome of their disease. So I'm going to explain to you very quickly, in an easy way, the pathophysiology of MS, because to understand the treatments and some of the emerging treatments and how they work, you have to understand what happens in MS. So here's a resting T cell. T cells are immune cells. Their goal is to keep you healthy and keep antigens or bacteria, funguses, foreign substances out of your body. And along comes an antigen-presenting cell. That's a macrophage that engulfs that fungus, bacteria, or virus, and then it keeps a little piece on the surface, and then it presents itself to a T cell. The T cell gets excited, and it starts proliferating more T cells, and they proliferate, and they proliferate, and they multiply, and they multiply. And then they release these cytokines and chemokines. They're attracted to the blood-brain barrier. So this over here is this is the blood-brain barrier here. This is the periphery. When we say periphery, we mean in the blood vessel, So these T cells are attracted to the blood-brain barrier. They release things that break down the blood-brain barrier. They go into the central nervous system here. There's a reactivation of T cells. But then what happens? T cells multiply. B cells, which are also immune cells, make antibodies. They're toxic to the myelin. This is a nerve cell, and the myelin starts being broke down. Sometimes the oligodendrocytes are targeted, and sometimes it's the axon itself. So when we talk about treatments, we're trying to do something to stop one of these processes along the way. So the ultimate goals of treatment are to prevent an accumulation of disability. That's what we're trying to do when we treat multiple sclerosis. When we talk to you about going on I'm just getting over a terrible upper respiratory infection. But when we talk to you about a treatment, we can see the future because we've worked in it many years, and so we want to make sure that you are on a treatment and adherent to it. We want to prevent relapses. We want to prevent new lesions on the MRI that I'm sure many of you have seen. We want to provide treatments that are safe, that are benefits outweigh the risks, and that you can take long-term, and then that have tolerable side effects. That's a very important issue because our goal is to help you maintain a quality of life. Now, some of the treatments, these are the things that we're trying to target. Some of the treatments decrease trafficking of leukocytes, T cells, white blood cells. Same thing. we're trying to decrease trafficking of those from the blood vessels into the central nervous system. Interferons do that, and Daclizumab does that. We want to reduce the number of circulating T cells in some cases. Alemtuzumab, mitoxantrone do that. And there's fingolimod or Gilenya that sequesters T cells, 70 to 75% of your T cells in lymph nodes. So it's sort of an artificial immunosuppression. Modulating the immune system, glatiramer acetate, dimethylfumarate, and teriflunomide do that. So we're targeting some area in the central nervous system. So these are all, or were partly all, not all, but these are most of the MS disease-modifying therapies. They're listed by year, except we just came out with Glatopa, which is a generic Copaxone that just came out a few weeks ago, and then all of these have come out through the years. The platform drugs, when we talk about them, those are the interferons and Copaxone. They're administered by injection, and then we had Gilenya was the first oral agent. Then we had others come out, and teriflunomide, Aubagio, and Tecfidera. Now, this is the mechanism of action. We don't have time to go over all of those. If you're interested in having the slide, I'll be happy to send it to you. Just let me know. So these are the glatiramer acetate came out. The 40 milligram glatiramer came out in 2014. Pegylated interferon, long-acting interferon, is given twice a month, once every 2 weeks by sub-Q injection. Is similar in its effect to all the other interferons. And then there's alemtuzumab, Lemtrada, which has just come out recently. And we only have about 3 patients on that drug yet, because this is a drug that isn't given first line. It's given to patients who fail the platform drugs or the oral drugs. So its risks are greater, and therefore we save it to when somebody isn't responding to other treatments. So let's talk about the safety. This is the big deal. So most patients who are on a disease-modifying therapy have to be monitored. They either have to have their CBC, their complete metabolic panel checked. They have to have their liver enzymes checked. They may have to have a lymphocyte subset to see if their white blood cells are too low. And so there are labs to be done. There's only one drug that doesn't require any lab work at all. Who knows what that is? Copaxone, that's right, Copaxone. So we do monitor Copaxone, though, and I'll get to why we do that. But there's a REMS program for some of the newer drugs coming out, the monoclonal antibodies, and that's because their risk might be a little bit greater, and they are greater in many cases than the earlier drugs that we've been using for a long time, many years. So the REMS program was developed by the Food and Drug Administration so that we can educate patients about the risk of the drug, we can educate providers and those that order the drug, we can educate them about the drug, and it's a way to monitor patients. It's sort of a reminder and a recommendation of a monitoring plan for patients who are on certain drugs. Tysabri has a REMS program, Lemtrada has a REMS program. So it's very important that you adhere and agree to that, because monitoring is going to be very important. So these are the injectable medications, and you know the side effects very well. Suicidal ideation, flu-like symptoms, congestive heart failure, seizure disorders. Those all sound really horrible, but most patients do not have those symptoms. They do have flu-like symptoms and injection site reactions, the most common ones, but we have to teach our patients about the major side effects. Category C, meaning that we think that there's a problem in animals. It may have showed a problem, but we have not had any, and they can cause some loss of the fetus if a woman is pregnant. And that's why we want our patients off treatment before they get pregnant, at least a couple of months. So we do complete blood counts, we do liver functions, we do thyroid functions, the TSH, to make sure that your interferon is not causing any change in your thyroid function. Very rare, but can happen. And then we have to monitor the skin. And then glutamer, we don't have to do any labs, but we monitor for lipoatrophy, and that's where if you inject in the same site all the time, and sometimes if you don't, you can get these areas of indentation. That's a loss of subcutaneous tissue, doesn't regenerate. Those indentations are permanent, and we don't want you to inject in those areas. So you can be allergic to Copaxone, but most people do very well, and it doesn't require monitoring. So then there's Fingolimod. That came out a little bit riskier now. We're getting into the newer generation and the risks related to those. So Gilenya or Fingolimod can cause a lower heart rate. It can cause hypertension. There's risk of infections, of visual changes, liver enzyme elevation. The visual changes are macular edema. And sometimes you can get a lung infection called PRES. So, and the first dose has to be given under monitoring, very close monitoring for 6 to 8 hours. You have to have EKG and all of that because we have to monitor for any side effect. Teriflunomide, dimethyl fumarate came out close to the same time. They are oral agents as well. Teriflunomide has an X, or Aubagio has an X rating. That means it did show problems in animal studies. We're not sure what it's going to do in people studies, but there have been a number of women who have stayed on this drug and who have had normal pregnancies. And if you want to know about that, you can go to their website and look that up. But they've had some pregnancies born. In fact, I think Patricia had a patient who had a normal baby on teriflunomide. Dimethyl fumarate, and of course we have to monitor the CBCs and the liver function studies. For teriflunomide, you have to have a PPD or be tested for tuberculosis. We can do that by lab study or a PPD, and there's other things that we need to do to monitor in monitoring for teriflunomide. Dimethyl fumarate and teriflunomide is a once-a-day tablet. Dimethyl fumarate is a twice-a-day tablet. And so we monitor the CBC and the liver functions. But with dimethyl fumarate, only 4% is cleared to the liver, so we don't usually see that rise in liver function. 60% is eliminated through breathing. So, and that's why you have to take it twice a day. Then we have natalizumab. We have, there has a number of adverse effects. One of them, multifocal leukoencephalopathy. So we monitor for that. We monitor the JC virus, titer. We look at the CBC, liver functions, and so forth. Mitoxantrone, we don't use as much anymore as an immunosuppressant because we learned that even 5 years after your last dose, you can have cardiac problems. So we tend to not use that. Some doctors use it in special cases when their patients are not responding to anything else. Alemtuzumab just came out. It can cause headache, nausea, rash, fatigue, and diarrhea. It can cause a dysfunction of the thyroid gland. You can actually lose the function of the thyroid gland, and that happened in somewhere 28 to 30% of patients on alemtuzumab. That's why we save this drug for patients who are failing every other treatment, and we do labs every month for, I think it's about a year. So we just had our first patient infused recently. Immunosuppressants we don't give during pregnancy. The baby is affected by that and can be lost. And then the others are a category C. And so that's why we want our patients off these drugs. So let me just talk about the potential future therapies. I think many of you want to know about that. Laquinimod has been studied for quite a while now. It is a drug that's being studied by Teva Neuroscience. The MOA is the mode of action. It works very much like Copaxone does, actually, because what it does is it upregulates, increases the number of T2 cells, which are the anti-inflammatory cells in your system, and the T1 are the pro-inflammatory cells that cause the problem in MS, and so it balances those out, and it does it very nicely. So it doesn't have any immunosuppressant action, but what they found in clinical trial was it had a strong anti-inflammatory action and that it had a significant impact on the brain and on the MRIs. It decreased volume loss, and it upregulated the brain-derived neurotrophic factor, which is a neuroprotectant. So it is a potentially a good drug. It didn't come, when it came out after their first phase 3 trial, it didn't have a great decrease in relapses, and so they went back. They didn't go to the FDA. They're still studying it. We expect it to be out by 2018. But you can see that it's well tolerated. 94% stayed in the clinical trial, finished the clinical trial, and that is an indication it's well tolerated. There were 2 studies, Bravo and Allegro. I think these are phase 2. They showed an annualized relapse rate, little disappointing at 21.3 and here 23, but what they found was that it had a significant impact on brain atrophy, and of course it works like a neuroprotectant. So we're excited about this drug. The future, more research is underway, as I said. Teva Neuroscience has another study called Arpegro, which is a primary progressive trial. We should get some data on that trial by 2017. Concerto is a phase 3 trial looking at 2 dosing options with laquinimod, a 0.6 and a 1.2, and they're looking here at disability progression as the primary outcome instead of relapses, because we think by preserving the brain that we may see less disease progression with this drug. So that study is ongoing. Rituximab, you've probably heard of. We use it most commonly in optic neuritis or in neuromyelitis optica or DeVick's spectrum disease. Those are not MS, but they're a spectrum of demyelinating diseases that affect the vision or the optic nerve. It had very promising phase 2 trials. It is an IV infusion given twice in 1 month, once every 2 weeks, and then it's not given usually for at least 6 months and sometimes longer. Hard to get approved by your insurance company. It causes a depletion of those pro-inflammatory B cells that release antibodies with a CD20 marker. The side effects, it did increase opportunistic infections. PML occurred in a study. They were looking at systemic lupus, and 2 patients died, and so that's why it never came to market, but it is still being used. So there is a phase 2 48-week trial that indicated 91% reduction in contrast lesions, and it did decrease relapses. And then there's a phase 2 96-week trial in primary progressive MS that was completed. It was not effective significantly in primary progressive MS, but look, it did decrease disability progression and had a benefit. It decreased contrasting lesions in patients who were under 51 years of age. So it was a small subset of patients that showed promising outcomes with this drug. So it may work in some and not in others. They're studying it still. They're looking at what dosing regimen is needed. They think that it probably could use a lower dosage, and these have fueled other treatments, studies in other treatments. This Rituximab is made by mice, the ovaries and mice cells, so it is not humanized, and the newer drugs coming out are fully humanized. This is a very exciting drug. Daclizumab is now at the FDA. The FDA is going to determine whether they're going to approve it or not. We hoped it would get an expedited review. It has not, so it probably won't be out until sometime next year. This is a drug that's being studied by, has been studied by Biogen IDEC. It's a humanized, part mice, part human, monoclonal antibody that works on T cells with a CD25 marker. But what it really does that's most important is that it expands these CD56 bright cells. Excuse me. Okay, the bright cells, which are cytotoxic to rapidly producing T cells. Has some side effects. There was 1 death due in the high dose of daclizumab to autoimmune hepatitis. So it will probably come out and that's the 300 milligram dose. It will probably come out with the 150 milligram dose. So I don't have time to go over these studies, but you can see the numbers are very promising. It was very robust in its outcome. What was significant about this trial is that 88% of the study subjects were free of disability progression for the 2 years they were on this drug. So this drug is very effective. So we're looking, they're doing a phase 3 trial now called DECIDE. The SELECT trial was a phase 2. You have to do both for the FDA. And so we're And that has been done. I'm sorry, it was done. But, and now it's at the FDA. Ocrelizumab is a monoclonal antibody. It's humanized, monoclonal. It kills those rapidly maturing B cells that cause antibodies that demyelinate those axons, and it's still being studied. So it does have a few more risks. They have a phase 2 trial that they've completed, was very effective. They looked at 2 dosing options. Oratorio is a primary progressive study that's enrolling 630 patients, is ongoing. We're very hopeful that it will have an effect, but Rituxan did not have the effect we wanted, and this is a drug that's very like it, except it's only more as humanized versus mice. And then Opera 2 and 1 and 2. Opera 1's been completed. Opera 2 is ongoing. We're doing that trial in our office. The patients who we're blinded, of course, if they're on placebo or if they're on ocrelizumab, and it's being compared to Rebev, but the patients who we believe are on treatment have not had any disease progression over the last 2 years. So we're very excited about that. So the data looks promising, and we don't know whether there will be any opportunistic infections. We haven't seen any with ocrelizumab like we did see in another study with Rituxan. So then let's talk about the future studies. This is very exciting. Biogen IDEC found a protein in your central nervous system that's produced by axons as well as the oligodendrocytes, which are the support cells for axons. And this protein is called LINGO-1. LINGO-1 actually has an effect, a negative effect on remyelination and regeneration of axons. So they looked at that protein and they developed a monoclonal antibody that's fully humanized called anti-LINGO-1. And what they're finding with anti-LINGO-1 is that it promotes remyelination and regeneration of axons. This is a very promising drug if it comes to market. It's going to be very effective in repair of those axons and that remyelination. They did a trial of 82 subjects who had optic neuritis, demyelinating lesions on the optic nerve, and they studied those individuals for a period of time. And what they found is that 53% in the clinical trial had remyelination of their optic nerves. It's very exciting. So this is very preliminary. They're doing a phase 2 trial now, so we're excited to see about that. Stem cells are always talked about all the time. Stem cells can be autologous stem cells, which are adult stem cells, which are taken from the person. They are immunosuppressed almost to death, and then there's a 20% fatality rate, and then they're given back their stem cells in hopes that it will improve or repair some of the damage that MS has caused. The problem is those are designated stem cells. They're not embryonic, and so we don't know if these stem cells will work. Mesenchymal stem cells, the same thing, taken from the adult, but they're not, the adult does not have to be immunosuppressed, and they're getting some promising work with mesenchymal stem cells. Embryonic, taken from the fetus, and that's a whole ethical issue right now, and there is some study being done on embryonic stem cells, but it's hard to get into those trials. I just had 2 patients that were in a trial at Northwestern in Chicago, and they're really doing well. Then there's something brand new, just being studied, induced pluripotent stem cells. Those are skin cells, your skin cells, which they take and they turn them into stem cells. You don't have to be immunosuppressed. They're yours, and they're finding that this is a very promising type of stem cell, and it doesn't have all the ethical issues related to the other type of stem cells. We know that estrogens and testosterone are anti-inflammatory. Estrogens are very anti-inflammatory. When the woman takes high doses of estrogen, she does improve. The problem is estrogens at high doses can cause cancers, as women know, and that's why it's a whole issue as we get older. Testosterone has a very anti-inflammatory effect in men. And so the thing is that patients can't stay on these forever. And the patients that were in the clinical trials that have been done, once they were taken off of the hormones, they went back to demyelinating and developing new lesions and so forth. But they're still studying hormone therapy. I've actually had a patient that went through that. So this is just talking about how we make treatment decisions. It is not an easy thing to make. I've seen a number of patients this week. Now we have, 13 treatments and 16 options, because some of them have more than one dose. And so we have to go over every therapy. So now it takes about an hour and a half to go over those. And then with the patient, we tell them what we think would work best for them, depending on their type of MS, the lesions that are in their central nervous system, and what they're willing to do, because patients, some are not willing to do injections, some are not willing to take a pill or do an IV infusion. And then we make that decision based on all of that information. The most important thing is that it is an evidence-based approach. Research has shown it to be a promising treatment, and we include the patient's feelings in that, and that the benefits outweigh the risks. If the risks to you, because you have other disease processes, other comorbidities, if the risks outweigh the benefits, you're not going to get a treatment that is going to be too risky for you. So let's talk just a second about adherence. We've talked about disease management, what we're trying to do. But let's talk about the factors that help us manage I got 5 minutes? Okay, so let's talk about the factors that go into just managing MS. Not just the treatments, but what do we do in managing this disease? We manage relapses. We look at treatment, and we manage symptoms. The symptom management issue is huge, because if we can't manage a symptom you have, we can't improve your quality of life. I think Tricia's going to talk about that some. So it's very important that if we put you on something for a symptom, if it doesn't work, then you need to communicate with your healthcare provider. We're getting better in some areas. Sensory pain, those are hard things to manage with neuropathic type symptoms, but we do make every effort to do that. We have to make sure that we do MRIs periodically, that we do the labs for safety periodically, and that we work with the patient on adherence, which we're going to talk about now. So what is adherence? Adherence is when the patient's active and they're managing their disease. They're voluntary, they collaborate with their healthcare provider, and they accept the plan of care, and they change their behavior to follow the plan of care because they want to get the best care possible. Adherence is something we want the patient to do. If you remember, we used in the dark ages called it compliance, but compliance means the patient does what we say. But we want it to be a unique situation where we come together and we both agree on the plan of care. The core elements of adherence are partnership with your healthcare provider, mutually established goals. We let the patient establish the goals. What are you here for? What do you want to see happen? And then we're going to enter into a therapeutic alliance with you. Now, patients that know me, that come to my office and know me, we have a mutual relationship, a therapeutic relationship. I might not agree with what you decide to do, and I'll tell you that. And you are open and should be open enough to tell me what you're willing to do. So, and then we come to some common ground. There are a lot of barriers to being adherent to your disease-modifying therapy. Knowledge deficits. We have to make sure you know exactly all the information you need about MS and about your treatment. You may have physical impairments which preclude you from doing injections. There may be cultural barriers that make you choose one treatment over another. Many patients will come in and say, my cousin Susan's on Copaxone. I want to be on Copaxone. And so your knowledge base is very important because we have to start where you are, with which treatment you want. Financial concerns, how many of you have no financial concerns with your treatment? I write the letters, I talk to the medical directors of the insurance companies, so it's, okay, I see you. So it is a huge issue. Cognitive deficits are an issue, and depression. The number one reason patients are not adherent is depression. And so we look for that and we talk about the barriers at each visit. These are the challenges: needle phobic, injection fatigue, perceived lack of efficacy. And the other day, a patient told me she stopped her treatment because she wasn't getting better. Is that the goal? What's the goal of treatment? Prevent further damage, further new lesions, further disability progression. That's right. So as a patient, be realistic in what your expectations of your treatment is. Evaluate your current knowledge. Advocate for yourself. So I tell patients sometimes when I've written that letter and I've talked to that medical director, call your insurance company yourself. And you talk to them as the consumer. Remember, you are the consumer, and this is your disease. So don't be afraid to talk to those people and be direct. I'm direct. So develop a therapeutic alliance with your provider. Address those barriers with your provider every visit, and be active in the development of that plan. If we ask you to do something you're not doing and you're not going to do, please let us know, because we'll work with you on any of those issues. So I'm going to let Tricia come. This is Tricia Pagnotta. She's a very good friend of mine. We don't work in the same office, but we both have a love for multiple sclerosis and our patients. And she'll tell you a little. She works at Neurological MS Center of Greater Orlando. I'm sorry. Okay, there you go.
Well, I'm always honored to follow Connie, and it is a hard act to follow. So bear with me. The other thing is that I'm now charged with getting us back on time. So there is no way that I could cover this topic in 30 minutes. I've been given 30 minutes to cover 3 topics, and so we're going to run through these rather quickly, but it's most important for me that the 30 minutes after this, we spend time in answering your questions. So I'm going to go through my topic as relapses, symptom management, and self-care. If I figure out how to get the slide. Okay. What is a relapse? This is still a question that persons ask me all the time, regardless of whether they're newly diagnosed or have been diagnosed for a long time. It can be new symptoms. Obviously, that's a little bit easier. New symptoms, yes. Or it can be worsening of old symptoms. So if you had a symptom in the past, let's say an optic neuritis, and that recovered and suddenly gets much worse, your vision is worse, that can be a relapse. It must last for at least 24 hours. So it's not something that can come and go. It has to last at least 24 hours, and most relapses last much longer than that. It cannot be related to anything else. So we're wanting to treat things that happen to the central nervous system, not something that is causing the central nervous system to misbehave. So it can't be related to any illness. It can't be related to heat. It can't be related to fatigue or medication side effects. And typically when we're talking about relapses, deciding whether it's a new relapse or not, we're looking at something that has occurred at least 30 days after the last relapse. So if it's occurred within that 30 days, it's still part of the relapse that you had that began within the 30 days, okay? And it may still need to be managed, but it's still part of that one relapse. So the term pseudo-relapse or UTOS phenomena, that's the things that cause you to have symptoms that are not coming from your central nervous system. So we talked about some of them: medications, alcohol, heat, sickness. Those things, that is not a relapse. And some of those things can last for longer than 24 hours. If you get an upper respiratory tract infection, if you get a urinary tract infection, that can last longer than 24 hours. So again, we need to tease that out. Your job is to tell us, our job is to figure it out. Treating a relapse. So the goal of treating a relapse. Now I tell all of my patients, and I want you all to understand, when you have a relapse, there is no guarantee that you are going to get back to your baseline. There is no guarantee that that will not affect you later. In fact, we know it will. But the goal of treating a relapse is to aid you in getting better faster. The other goal is to provide an environment where healing can occur. So if we pull out some of that inflammation, we believe at a cellular level that those cytokines and things are being reduced and healing can occur. So those are the two goals, the two reasons why we treat relapses. Relapses can be treated with steroids. You can take oral steroids, you can get IV steroids. There's a lot of side effects that go along with steroids, and so, just make sure that you're talking to your healthcare provider about how you handle a relapse and what you've been treated with. The other option is Athgar. That is your own body's steroid. It has a steroid effect. There's some melanocortin peptides that also work on other things in your immune system, deregulate some of those other cytokines, macrophages, and things that are happening. So we believe Athgar, in addition to having the steroid effect, also has another way of modulating your immune system. And so that can be used. One of the biggest benefits of Athgar, other than its other properties against your immune system, is you don't have to have an IV. You can do it at home. And so many persons have to be hospitalized or have strangers come into their house who may not be able to get their IVs. So Athgar can be given at home. You can self-administer it, or somebody in your family can administer it to you. Then there is IVIG and plasmapheresis. Most of those cases, you have to go to the hospital to get either your blood washed out by a IV infusion that's taking all of the antibodies out, or actually put on like a dialysis machine is what plasmapheresis is, and it washes out your body. So that's how we treat acutely with medications. The other thing is you need to be open to therapy. So if you have a optic neuritis, you might need occupational therapy to help you. You might need physical therapy. If you have weakness, you definitely need occupational therapy and physical therapy. We know the brain is plastic at a certain point. So I have persons that say, oh yes, I want the steroid, I want the Athgar, it makes me so much better, but I really don't want, co-pays, I really don't want to go to therapy. That therapy is going to help that brain relearn. So therapies are extremely important, so please be open to that. Okay, so symptoms. This list of symptoms. Could I cover all of that in 30 minutes? No, I could take 30 days to cover all of this. But one of the things I want you to know that some of these symptoms, they're interrelated. So, and many of these symptoms, some of the caregivers in the room may recognize some of these symptoms, and they don't have MS. So some of these symptoms occur in other disease states, not just MS. So that makes it complicated. So fatigue, who doesn't get fatigued? Everybody gets a little fatigued. But the fatigue of MS is so much different. Bladder dysfunction, impaired mobility, cognitive dysfunction, sexual dysfunction, this whole list of things. You'll be able to get these slides from Stuart, so keep an eye on those. The goal for you is to know what your symptoms are and to report those to a healthcare provider. So in classifying symptoms, we talk about symptoms that are primary, secondary, and tertiary. So the primary symptoms are coming from demyelination of your central nervous system. That's coming from your disease directly from your multiple sclerosis. It can be things like fatigue, tremor, weakness, pain, bowel, bladder, visual problems. Secondary symptoms are things that are coming from your impairment, the disability that you now have because of your primary problem, the demyelination. So that can be falls, urinary tract infections, injuries, insomnia. Tertiary symptoms are things that, because of your symptoms, it's making it more difficult for you maybe to have relations, financial issues, the stigma of disability, depression. Our goal of treatment is to avoid symptoms. So primary goal is not to have the primary symptoms in the first place. That's why you take a disease-modifying therapy, so that you don't get symptoms. You don't get more symptoms. And then to avoid the secondary and tertiary symptoms. So it really takes a village to treat persons who have MS. And so I just really want to emphasize that. You are in the center. It's all about you, but all about you requires several people to treat you. And so I hope that most of you are treated in an office where there's a neurologist and a nurse practitioner, and maybe it's a PA. But we bring different things to the plate, and it's a wonderful collaborative relationship we have. And most of us use our own physical therapist, and we have our occupational therapist, speech therapist, nurse psychologist, ophthalmologist, social workers. All of these persons are extremely important in helping manage your symptoms. It's not one person. You're in the middle, and the rest, all of these persons help us help you get better. So again, I could not talk about every symptom, so I picked a few. Weakness in MS, we know that weakness comes from the lesions you get in your brain and your spinal cord. It makes the electrical conductivity difficult, and so it's all about where it's located. If you have a lesion way out in the periphery in your brain, I tell persons to think of this funnel. So if this is the funnel out like this, way out here, is not going to affect as much as down here where my mouth is. So right in my brainstem or in my spinal cord, in my neck, if I've got lesions there, I'm going to be much more disabled than these lesions way out here. Over time, those will change and cause problems, but so primary weakness in MS is coming from, again, this degeneration of the axon. And so you see here on this picture how it can just be damaged a little, and the electrical impulse can run through there, and it's just slower. So it may take you longer to move, but you still are able to move. And then maybe there's a problem where there's just a total axon cut, and so then there's no ability to go through there. So persons think, I've had several family members say, well, if she just exercised a little more, it would get better. And so exercise does help, but you can overdo it, and exercising, building strength will not necessarily help this, and oftentimes increases the weakness. So again, it's important to be working with a therapist. So primary weakness, there's two types. The acute is a relapse when you have hemiparesis or quadriparesis, so either one half of your body or all four areas of your body. Again, that's related to a relapse. Chronic becomes the disability, and that can be things like spasticity, gait problems. I use the analogy of a broken light fixture. If the light fixture is broken and you put a new bulb in it, it's not going to work because it's the fixture. So, again, the issue is trying to treat the cause and then work to repair that fixture. And with physical therapy and things, you can teach your brain to go another way. Secondary weakness comes from things like fatigue, poor repetition, deconditioning, not eating well, not resting well, chronic pain, medications. Most of the medications we give people cause sedation and different side effects, anxiety, depression. Those things can lead to weakness. The feeling of weakness, that can be from other diseases. Hypothyroidism causes persons to feel generally weak. Anemia, illnesses, diabetes, heart disease. So again, it's very important to be talking to your healthcare provider about this so we can look for things, and is it coming from your MS or is it not? So conquering weakness, it's a collaborative effort between your healthcare provider and the whole rehabilitation team. Developing exercises that promote strengthening, coordination, stretching, getting rid of some of that spasticity, maintaining the muscles so they don't atrophy. Considering assistive devices. And so I've seen a couple people walking today, and I looked at one person and I'm like, man, if she just had an AFO, she would probably walk so much better. So being open to that, things like that with your rehab team, using a walker or using a cane. I understand that these things, I don't have a disability, and I understand that these things must be terrible to have to use these. But as I tell persons, it's much worse to be laying on the sidewalk, I think. So just consider that. And it may be temporary until you get stronger, and then you can get rid of that. And then considering medications. We know that the walking pill, as Stuart talked about, Ampera. So what Ampera does is it stops the potassium from being leaked out and helps speed the conduction of these damaged cells. And so in some individuals, that has helped their walking tremendously. They are doing studies with Ampera looking at other ways that this helps. We know that there have been persons who have reported that their vision has improved, that their upper extremity has improved, and so we're looking at that. But right now, it's only FDA indicated for walking. Other things like baclofen and Xanaflex helping with spasticity. So those are medications that can help with weakness. Fatigue. Fatigue is the most common disabling symptom in MS, and it can appear early in the disease. It can appear before the disease. It occurs sometimes without any warning, but it can be precipitated by heat, humidity, cold. It prevents a person from being able to sustain their physical functioning and makes it difficult for being productive, and often is one of the symptoms that requires persons to leave the workforce. There can be acute versus chronic fatigue. Acute fatigue, I ask persons to look for this because acute fatigue oftentimes is associated with a new lesion. So if you know yourself and you know your body and you know that, well, this is my certain, every day at 2 o'clock, if I don't take a nap, I'm going to be wiped out. If you know what your level of fatigue is and suddenly that changes and you have no other explanation for that, you didn't get sick, you don't have any new diseases, then you have to consider that that could be a relapse and that you should talk to your healthcare provider. Chronic fatigue is that lasts more than 50% of the time for greater than 6 weeks. And so that becomes part of your disability. The clinical characteristics of fatigue, it can be an overwhelming sense of sleepiness. It can be constant tiredness. It can be a lack of energy. It can be feeling exhausted, not necessarily, again, related to disability. It may cause motor function problems, cognitive problems. We know that we don't fully understand this. But as you read this list of things, some of these are, again, can be common of other things. So working with us to figure out what is fatigue and what might be other things. So other things that cause fatigue. So it's a significant problem. We know that there is fatigue related to MS. We know that there's fatigue related to other physical symptoms and other physical health problems. There's fatigue related to persons who don't sleep. And so learning about, do you have a sleep disorder? Is your MS pain keeping you awake? Are there problems with psychological problems? Are you anxious? Are you stressed? Is there something going on in your life? Are you depressed? Is there something in your environment? Physical, social, and cultural. There are many persons, men and women, who feel their role is X, and if I don't do all of those things that are encompassed in my role, then I'm not as worth to my family as I think I should be, so they won't give up certain things. That's culturally based, and so learning to work with that. And then there is normal fatigue. We all get a little fatigued, so there is normal fatigue. So there are things that you can do other than take medications. If you're smoking, absolutely need to stop smoking. Smoking is going to make your disease worse. It's also going to make all of your symptoms worse, and fatigue included. You should be eating a healthy diet. You should be getting adequate sleep. You should be planning ahead. Try to think about, well, what do I have to do, and make sure that you have everything together. Trying to conserve energy. So using a purse or a bag or whatever, so that you put everything together so that you're not taking 3 and 4 trips in and out to get things. So thinking about that. Taking naps, drinking lots of liquids, cool liquids, staying cool. Personal fitness program to keep from being deconditioned. Relaxation exercises help your mind relax and keep you from being stressed. And accepting help. Accepting help is extremely important. These are the drugs. There's several of them, but I just want to point out that there is no FDA-approved drug for treating fatigue and MS. So oftentimes when I'm prescribing a drug to treat fatigue and MS, I'm asking for other things. And I actually put it under the diagnosis something other than MS most of the time if I can. So if you are all in the workforce, then that's important. Do you work 9 to 5? If you do not work 9 to 5, then you work some kind of shift work, and I can put down that you work shift work. So for some of these drugs that require lots of prior authorization. So work with us and be available to help us out. A lot of these drugs have a lot of side effects, so again, you have to talk to your healthcare provider about that. Bladder dysfunction can occur in 70 to 80% of persons with multiple sclerosis. It is also a thing that can happen to persons in general. But in multiple sclerosis, 70 to 80% of persons will have bladder dysfunction. Inability to store some of the symptoms are urgency, the need to run to the bathroom very quickly, frequency, going several times, incontinence, or voiding at nighttime. The inability to empty can also have urgency, but you get in the bathroom and you can't go. That's hesitancy. I got to go, but you get there and you can't go. Double voiding. So you're in the bathroom, you go to the bathroom, and you still feel full and void again. And frequency and incomplete emptying. Then you can have a combination. So it can be difficult to diagnose this. The most common, we do post-void residuals, and we can do that either by catheterizing someone or using a bladder scanner. Send persons off for urodynamics. It's very extremely important to get a urology consult and to be clear what we're treating before we're just throwing drugs at persons, because again, they have side effects, and a lot of those drugs have cognitive side effects. So being very careful that we know what we're treating and looking for other things that might cause this other than MS. Urinary tract infections, pelvic floor problems in women, benign prostate problems in men. And so the goal of treating bladder problems is to make sure that we maintain normal renal function. We don't want persons' kidneys to get hurt. We want persons to establish regular voiding patterns. And we want to help reduce the problems that cause quality of life issues. There's non-pharmacological ways, again, watching your diet, making sure you're not having too much caffeine, exercising and training your bladder, and you may need to catheterize. There's pharmacological drugs that we can use for any one of those problems, and avoiding urinary tract infections as part of prevention. Why do we treat this? Well, I think that you all could tell me why we treat this much more, but I encourage patients to tell me about these problems so that we can treat this, and most people don't like to talk about this, but it's something extremely important. So self-care. Building resilience means having the right attitude, empowering yourself to be more than MS, redefining yourself, and to have hope for a full life. So the capability of a strained body to recover its size and shape, and the ability to recover from and adjust easily to misfortune is what resilience is. So we want persons to have resilience. What about MS threatens resilience? Well, just the mere fact of MS, the fact that this is a chronic disease that's characterized by relapses and disability, threatens our ability to be functional and be hopeful. And so there are neuropsychological complications that can arise partly from the inflammation and degeneration. And then there's chronic, the things that threaten your personal autonomy, independence, dignity, and future plans. So things that are characteristics of or threaten resilience is anxiety, depression, cognitive impairment, irritability, and anger. Less common are disinhibition, psychosis, apathy, and behavior problems. So what's important? So stay hopeful, please. This, we need persons, there's 13 disease-modifying drugs now. You're in a great area, as Connie said. We know a lot about MS. Both Connie and I have clinical research trials. We know a lot about these things. So you're in a great area to be treated. So be hopeful about that. Be hopeful about the fact that I hope that not only with these remyelination drugs, but also as we're getting more and more, I anticipate that one day we will have a cure for MS. And so I try to tell persons that. Make sure that you have a partnership with a provider, and that you and that person respect each other as an individual, that you accept one another, that there's a collaboration, that you bring to the table things and that person shares with you. So get ready for your appointment. Make sure that you have all of your things together, that you have all of the drugs, you have all of your new medical problems, and that you're able to share, and you share what's going on in your life. Know that your healthcare provider should work with that and be respectful and hold everything you say in confidentiality. So again, strategies: being self-aware, self-regulating, optimistic, mental agility, again, thinking outside of the box. Think of the things that you're strong in and build on those and make connections with others. So programs like this are exceptionally fantastic because it allows you to build with other individuals. Focus on what you can do. So everything I talked to you about had drugs and had other things. So focus on what you can do. Look at the opportunities that your MS provides you as, well, maybe this is a way for me to learn or have something different. What can you do every day? You can eat right every day. You can sleep. You can hydrate. You can have the right attitude and get support from others. So who am I in the face of all of this? So this comes from a Dr. Frankel, who was a neurologist, a psychologist, and was a Holocaust survivor. He said, everything can be taken away from a man but one thing, the last of human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. So I leave that with you. And I think now we're for questions and answers.
So what we're going to do here today is I'm going to be on one side of the room, and Maida Gonzalez, who's one of our volunteers, she's going to be on the other side of the room. For those on that side of the room, Maida's wearing green, all right? And just hold up your hand, because we don't know if you have a question unless you hold up your hand. And I'm going to be on this side, and we're going to alternate back and forth, okay? So anybody here, let me know who you are if you want to ask a question, but that side's going first.
Yes, I was asked by a friend, does the use of alcohol affect two different things, the disease, the meds, or both?
Both. So alcohol is a toxin to the brain, causes brain atrophy, and so yes, it affects the disease in that you already have a disease that's causing potentially atrophy of the brain, so you don't need anything to speed the atrophy of your brain. The other thing is alcohol is highly associated with strokes. So that's another pathology that can be going on in your brain by using alcohol. But alcohol is a toxin initially to your cerebellum. Very rapidly gets up to your cerebellum and causes problems with gait and balance. And so, you know, the t-shirt, I'm not drunk, I have MS, speaks volumes to the fact that I don't have MS, but if I got drunk, I wouldn't be able to stand up here and manipulate around. So if you already have problems with that and you're anesthetizing the area that you need, you can anticipate that you're going to have a lot more problems, and alcohol goes against most of the medicines you have in that it can intensify the sedation of the medications. It also is broken down through your liver. Your body recognizes that alcohol is not something that you should have, and so your liver immediately starts ramping up. I've got to get rid of, I've got to get rid of, I've got to get rid of. And so it can cause damage to your liver, but while the liver is actually going faster to get rid of this, you can have a reduction of some of the drugs or an elevation of levels of some drugs and then a dramatic reduction of the level of those drugs. And so there's nothing good about alcohol.
No more partying, everybody. Next question.
My question is also in regards to what we drink, and that is diet soda or things with aspartame. Artificial sweeteners, and how it affects us with MS?
So aspartame we know is
oh, that's okay. She's doing symptoms. So aspartame, I don't care for sweeteners because they irritate the bladder. And so for bladder function, they can be an irritant. And so, you know, really the thing is, I would drink natural drinks. Sodas can be a problem anyway, plus with the real sugar in them. Too much sugar, you know, what does too much sugar do? That's toxic to MS. And remember, so you really shouldn't eat a lot of sugar, you shouldn't eat a lot of salt, you shouldn't be obese, because all of those things leads to more problems with MS. But as far as the sugar sweeteners, I don't like them because of the bladder irritation. Do you know another reason? Okay. Headaches, yeah. So I would be cautious with them. The thing is, if you're going to drink Cokes, drink the regular Coke and just with moderation. I think there's two things you could do for yourself that can revolutionize your life. Drink lots of water and sleep 8 hours a day. That is going to make a total difference in your life, trust me. Dr. Robert, many of you know, he's been retired 8 years now, and he used to say that 50% of taking care of this disease, of living with this disease, is living right, taking care of yourself, having healthy outlook, and maintaining health in all aspects of your life. And then Pat Coyle, who's in New York, some of you know Pat Coyle. We bow when she enters the room. She's a physician. We love her. She says there's a new disease-modifying therapy for primary progressive MS, and it's health maintenance and wellness. And so we've all jumped on that bandwagon because it's good for everybody to practice.
You two can both give your answers. If you have anything else to say also, just add into it.
Okay, it's me again. I just wanted to say I work for a specialty pharmacy. This isn't a MS patient. I have a friend that has Hep C, and they just came out with a cure for it. And anytime you have something good like that come out, it gives hope to all the other diseases, is how I look at it.
Great, thank you for sharing that.
All right, from this side.
What's going on in Europe as far as the pharmacology that's available?
Okay, so as far as what's going on in Europe, they're doing some same clinical trials that we are, and you know, we know that Lemtrada was in Europe approved long before it was approved here in the United States. The health economics in Europe is much different in that they're socialized, and so their formulary of drugs is much different, and so it's harder sometimes to get on drugs. They embrace a lot of research that is related to medications that are very inexpensive, and one of them they're looking at minocycline as an antibiotic, and to see if that reduces inflammation and degeneration of the brain. So we get a lot of studies from Europe looking at novel therapies that, in addition to our current disease-modifying therapies. Did that answer your question?
I just want to say that is true. It's hard to get on treatment in Europe, and so most of the people that live in, especially Northern Europe, Northern Russia, Germany, and so forth, they go into clinical trials. In fact, a lot of the trials we talked about today, the majority of the patients that were in those trials were from Europe. We do, in America, it's hard to find people that have never been on a treatment because we have access. And so if they're looking for naive patients and they're trying to do studies in patients who haven't been on anything, they go right to Europe in most cases. So most of the trials are completed there. That's right.
Okay, got one here.
Yes, no. Okay. You got one here?
I'll hold it.
Oh, okay. Hi. I saw a slide that had the names of all the drugs that were used to help combat fatigue, and they all appeared to be antidepressants. Is that correct? Or, and if so, you know, I just didn't get the connection.
Okay, so not all of them were antidepressants. A good number of them were antidepressants. So writing the chemicals in the brain, some antidepressants have a stimulating effect, but also serotonin is a stimulating effect for persons. So that's the connection with antidepressants. And the other thing is that some persons' fatigue is related to depression. But the other ones that were up there were selective drugs that go up and hit the reticular activating system. Nuvigil and Provigil are both very selective and hit the reticular activating system, whereas something like Adderall or Ritalin is a more broad spectrum. So you think of either doing a straight shot right to the reticular activating system or taking a buckshot and hitting the whole brain. So there were stimulants up there as well as antidepressants.
I just have one comment. Last night on national news, they showed that
Pepsi and Coca-Cola are taking aspartame out of their drinks, and they're switching to Splenda now.
Yes, they are. That they're trying to get the edge.
Hey, ladies. Night, I'm here. Oh, well, you should by now. I don't believe in coincidence and everything happened for a reason. That's my belief. And you mentioned anxiety, and I just read in the International Journal of MS Care about anxiety. It's a lot of information. Of course, I don't understand half of it because that is for medical terms. I get this by accident. But that is the MS is causing, or part of the brain, or the lesions in the brain, what is causing us to have that anxiety, which in my case I never had. And I know that stress triggered that too. But even in quiet moments, I still have the anxiety. So it's something that the lesions in the brain cause for the anxiety?
Yes. So the inflammation and the degeneration of cells can cause anxiety in persons, can cause apathy, and can cause depression. So, I have persons that tell me all the time, I'm not a person that's depressed, but it's the chemical change from those neurons that are being damaged that cause that in an individual.
And remember, anxiety, there's when we say MS can lead to depression, we don't just mean depression. It's like an umbrella. There's a whole series of emotional disorders that occur in MS, and we blanket them under the term depression, but they're not all just depression. Many times it's anxiety, many times it's anger. It's just different things, and we believe that MS does cause those. So, but we treat them pretty similarly.
I know this is a urologic procedure, but I'm just wondering if you can explain what the stem procedure is.
The stem cell? Well, it depends on what you're, I'm sorry.
I don't think she said stem cell.
What she said?
Stem.
Oh, the neurostem? Oh,
yeah.
you mean like in the bladder?
Yeah.
Oh,
bladder
okay,
stem.
I'm sorry. I really, do you know? I don't really know. That's a urologic procedure, but apparently it uses like the TENS unit, electrical type current, and it stimulates the bladder to empty and so forth. But other than that, it's all of the stems devices are similar, whether you wear one on your leg, you use a device in your bladder, they're all trying to stimulate something. So that's all I know about it. But I do know that when you have a neurostem, that we weren't able to do MRIs, so that's an issue to know about. And in a lot of people, it really works. So.
Next question, because in the brochure it says you can do MRI of the
brain.
Right,
that's the new one she was just mentioning.
And is that true, or?
Well, I don't know. I had a patient the other day who said, "Oh, you can do the MRI with the stem." So my goal was to find out whether you had to turn it off or can you leave it on. Do you know?
You can leave them on, but it's the field of the MRI. And brain, but you also, the field of the MRI, you cannot do a 3 Tesla. So even the newer bladder stem, you cannot do a 3 Tesla, so you have to back down to a 1.5 and the 0.75, but the 1.5 is acceptable with a bladder stem device.
Just so you all know that MS Views and News has the Learning Channel on YouTube, okay? And this topic was brought up in the past when we had urologists speaking at our programs. In fact, last year when we did our symposium, we had a neurourologist from here in the Orlando area that spoke about this as well, and we've had other urologists speak about the same issue, the stem that she's talking about. So if you want to know more about it, you can always turn on to the MS Views and News Learning Channel on YouTube and find one of the programs where a urologist is speaking, and they do answer this question at every one of those programs. Next question.
If you have a patient with relapsing remitting on Avonex and they transition to secondary progressive, would you still keep them on Avonex?
Well, that is a question. You might get 6 different answers from 6 different physicians. even in secondary progressive MS, you can still have relapses. You can have a reactivation of your disease. We in our center, I'm at the MS Care Center of Neurological Services. Dr. Jacobs is my partner physician, and Jennifer is our other nurse practitioner. We do not take patients off treatment at secondary progressive. We had some patients come to us a number of years ago who had been taken off of their treatment after they'd had MS 10 or 15 years, and they became very active. And actually, we did spinal taps on those individuals, and they had high levels of O-bands. So we tend to keep patients on. And we've talked to guest physicians who've come to our center who work throughout the country, and almost every physician who specializes in MS will keep patients on even during that time. It may prevent a reactivation or the relapses that may happen in secondary progressive. But when we do take a patient off, you know, that's after they've had a series of MRIs that show no activity, they've had no new symptoms, and then we do MRIs every 6 months to make sure their MS stays inactive. Okay, so most of you know that people who have relapsing remitting MS, sometime between 10 and 20 years, they'll transition to a secondary progressive phase where they have fewer relapses. They may not have any relapses, but those lesions that were developed early in the disease, first 5 to 10 years, become the problem then, and you show progression. So you can still show progression and it not, you'll feel like a relapse, but it's not actually a relapse. So we don't. Do y'all do something different?
We don't take persons off. We may even change therapy, though, if the drug that you're on is causing you side effects. So, but we're very careful to how we word your medical record, because that's the key. If your medical record reflects that you have secondary progressive and we don't qualify with relapses, then your insurance company may give us quite a bit of difficulty keeping you on a drug.
They ask you when we do your prior authorization forms. They're very tricky. They ask you the same question 3 ways, so.
Next question's over here.
Yes, hi. Getting MRIs done and getting labs done, everything comes back, no new lesions, your labs come down perfect, but I'm having a bunch of issues. Walking, lose balance, vision, fatigue, tired, and everything else. Why is that?
So we know that MRI just shows us a part of the disease. When we're looking at persons treating MS, it's relapses, it's MRI activity, and disability. We know that there is gray matter disease that does not show up well on MRI. So if we're sure that all of the symptoms that you're describing are not coming from some other secondary cause, some other illness, other deconditioning or medications or something else, we're sure that's coming from your MS. That's increased disability, and you could be offered a different disease-modifying therapy.
But there's a series of questions we're going to ask you to try to figure out what's going on with you. Are you on any new medications, like Tricia said? How long have you had MS? Have you had MS more than 7 years and you haven't had relapses? Maybe you're transitioning. But Tricia's right. So when we look for gray matter disease, which we cannot see on the MRI, we look for lesions at the periphery of the brain. So they're more what we call juxtacortical, but they abut or right up against the gray matter. Remember, on the MRIs, your white matter looks darker, your gray matter looks lighter. And if you have lesions that sort of are right up around the gray matter, usually those lesions spill over into the gray matter. So, and that's gray matter disease. We do know that more people with primary progressive MS have gray matter disease. They don't have very many lesions we can see, and it's mostly in the gray matter, and that's very debilitating. So gray matter lesions do cause significant progression. So.
Before we go to the next question, just want to say we have 15 minutes left of questions from this Q&A. Thank you.
Are there any studies for transdermal medications? Transdermal. Subcutaneous. Mm-hmm.
What was her question?
She's asking if they have any transdermal medications. I think that's what she said. Maybe patches?
Yeah,
Well, we have pain patches, and there are patches for, some of the, dopamine drugs have patches, but there's not a patch for a disease-modifying therapy. That's a very good question. That would be nice. But at this moment in time, we don't have a patch for a disease-modifying therapy.
I think they studied that years ago, but it wasn't effective. I can't even remember the name of the drug, but it was at one time they looked into that, and it didn't prove to be effective. So, because what we're trying to do with these drugs is get them right in the fastest way we can get them into the brain and the spinal cord, and that's probably why it wasn't effective.
They should think about using alcohol to get there.
Okay.
Okay. What are the chances of my MS being passed on to my children and grandchildren?
Well, that's a very good question. We do know that if you have a first-degree relative with MS and you have MS, it increases the chances by 40%. But it's very low. If nobody else in your family has MS, the chances of your children or grandchildren getting it are only a few percent. Very, very uncommon. But MS does tend to jump generations. Patricia and I work in an MS center. We do research, so we see a lot of the aggregations of families. I have a family with 4 daughters. All 4 daughters have MS. But there's no history of MS in the whole family. So we do see those aggregations. And so, but the chances of you passing it on are very low. All of those things that we talked about have to come together. The environmental factors, the genetic factors, which would obviously be there, and then the dysregulation of the immune system. Low percent, not more than 6% if nobody else has it. Yeah.
Okay, next one over here.
Where is the stand with therapeutic marijuana and MS going right now?
Well, that's a very good question. I can tell you that as nurse practitioners, we will never be able to write for it, most likely. But the doctors can write for it when it didn't pass, did it, this last time? Yeah. So, which was a surprise because we thought there was about 70% that. Uh-huh. I see.
Know that we cannot hear you unless there's a microphone there.
So some doctors are going to be pro-marijuana, but not everybody's going to get an open prescription. Just remember, it's going to be written, those prescriptions will be written for very specific issues. So if you walk in and ask for a prescription, ask Dr. Jacobs for a prescription of marijuana, he's most of the time he will not write it. So very specific. I did learn the other day that there's great research going on with seizures and marijuana. I have a grandson with epilepsy, and they're using marijuana at low doses even in the pediatric population to stop refractory seizures. So that was something I learned. So I think there are some benefits to it. But I don't, and a lot of physicians, like Tricia said when she gave her presentation, we all do a lot of off-label work. We do a lot of supplementation with our patients. Marijuana would fall in that category, but it's not going to be a blanket prescription for everybody.
Okay, we're only going to have time for another 2 questions each. Okay? Sorry, did you want to say something? Okay.
Okay, I have 2 questions, but can you explain what a black hole is?
Black hole is very easy. So that is an area where your brain, the axons and neurons in that area have completely been killed, and cerebral spinal fluid now lives in that area. So it's really an area where there is no brain tissue at all. So lesions in your brain can come, can go. You can have T2 lesions, which are the white fluffy clouds. They can go away and we can't see them, and we believe in that area that there's still damaged tissue, even though we can't see it. But then when there's a black hole, there's no tissue there at all. So the only way to recover from a black hole is to depend on all the neighborhood cells around to take over the place for what those cells used to do.
Let me just make a comment. So if you if on MRI we see no new lesions, no gadolinium-enhancing lesions, but we see an increase in black holes. That's a degenerative process. That means your MS is not only inflammatory, but it's degenerative. And so at that point, that means your treatment's not working. We need to look beyond that. And there are some medications like Copaxone who upregulates that brain neurotrophic factor, which is that prevents damage. And so that would be a good option. Laquinimod, when it comes out, hopefully it has a remarkable effect on the brain as well. So we don't like black holes because black holes tend to lead to atrophy of the brain if you have a lot of them, and it also correlates with cognitive dysfunction. So remember, MS is an inflammatory disease. The inflammation can be so severe in a particular lesion that it transects through those axons. So that's why we treat relapses and enhancing lesions as soon as we can. Tricia and I both are very pro-treatment of relapses and enhancing lesions to maybe down-regulate that whole inflammatory process very quickly. And it's why we want patients on treatment as well. So remember, with one lesion, the lesions that occur, the most common size or average size of an MS lesion is 5 to 7 millimeters. Many patients have 12 millimeters, 15 millimeters. Those are too big. If those lesions become black holes, it means that every T cell in that lesion, which is about 10 to 12,000 per lesion, was lost. You may have 14 billion nerve cells in your central nervous system, but you don't need to lose 12,000. And so black holes are taken very seriously. Okay.
Okay. My question is, SPMS, there are no drugs for that type of disease. Why are we taking them?
So that was a previous question. So secondary progressive multiple sclerosis is when a person's had relapsing first, and somewhere between 7 to 20 years they transition to a more progressive phase. And we look for that. We look for the same MRI every time we do it. We look for no new symptoms. There are indicators of secondary progressive. But we continue to treat because many people who transition to secondary progressive MS still have gadolinium-enhancing lesions on MRI. Some of them are still developing black holes. So as I said before, we received a number of patients from another practice in Central Florida where they take patients off drug at 10 and 15 years. We don't agree with that. But what we were seeing in those individuals is they were reactivating. You know, when you've modulated the immune system for 10, 15, 20 years, and then you suddenly stop taking treatment, then your immune system may become active. Or it may be that you have a relapse. We don't know if you're going to have a relapse in secondary progressive, but if you do, it could be profound. And that's what we're trying to modulate so that we can prevent that. So those of us that work in MS full time, that have MS centers, we tend to see that over time, and so we keep our patients on treatment. But like I said, if you don't have any new symptoms over a period of time, you don't have any new lesions on MRI, and I'm talking about several years, patients do ask to come off treatment occasionally. We take them off treatment, but we watch them very carefully. We do serial MRIs. If there's any activity at all, we put them right back on treatment. So that's a fair question, though, to talk to your healthcare provider about.
This side of the room? Last one from this side of the room.
My husband and I do a lot of research on the internet, and we recently found a supplement in Australia that supposedly reverses MS in mice, and it's called MitoQ. It's a type of CoQ10. And I was wondering if you've heard about it and if you have any comments.
We hear, Tricia and I, about almost every other visit with patients, hear about a supplement that's somewhere. And let me just caution you, I'm not saying that it doesn't work, if I were a patient considering a supplement, now I take CoQ10 for another reason, but and I take other supplements, but I know why I'm taking them and what effect I'm looking for. So you should ask for the research. You can write the company that's doing the research. If you can't find research, then it's likely that they haven't documented it, they haven't published it, and if they haven't published their research, you need to ask the question, why not? Because there's a supplement out there now called Protandim. The people that make Protandim did an article, and they say, we are partnered with Biogen Idec. When it was Biogen Idec, we partnered with them. They know about Protandim. It does the same thing as one of their drugs, as Tecfidera. And so I called the scientists at Biogen, and they didn't know anything about it. You must be very careful, because these supplementation companies will make statements to get you to use their supplement. So you need to know the outcomes of the research. You need the published article. Take the published article to your healthcare provider, and we'll go over it with you. Okay?
Last one over here.
This will be a quick one. Is there any hope in the near future, for progressive MS yet?
Oh, yeah, we talked about a couple of things. There's every trial now that is studied for relapsing remitting MS, almost all of them are doing primary progressive, and to see if there's any benefit. So they may not have significant effects, but there's usually a subset. Just like with Copaxone, when they did the Gala trial, they found there was a subset of men who did well on Copaxone and their disease did not progress. And so in our practice, we put our primary progressive men on Copaxone. But it may help the individual, may not help the whole masses. So, and then there were other drugs we talked about that are still looking at primary progressive MS. You mean as a blanket, secondary, what are you talking about? Primary progressive and progressive are the same. Well, that's what I'm saying. When you say progressive MS, we include primary progressive in that. That's primary progressive MS. So you're talking about progression from the beginning and you progress over time. That's primary progressive. Okay? Okay.
All right. Thank you, ladies. Thank you, Patricia Pagnotta and Connie Easterling. You know, these two exceptional nurse practitioners in this area, you guys are so lucky, because there are other areas of the country that do not have nurse practitioners in the abundance that you do in Central Florida. And I'm talking about from Tampa to Melbourne. And like in South Florida, I think they only have one that gets out there and speaks, and the patients all know. But you guys have 4 or 5 different people in this area, and these two ladies just are exceptional. And that's why we love to have them at our programs. So I do thank them. Connie, Tricia, thank you.